Welcome to GI Disorders Part 3, Gastroesophageal Reflux Disease. You're familiar with the pathophysiology associated with this. Basically, it's an incompetent, relaxed sphincter at the bottom of the esophagus. And what ends up happening is gastric contents reflux back up into the esophagus. It can lead to esophagitis as well as esophageal ulcers. And on our little kids especially, it can cause lung damage, apnea, and all related to the pulmonary aspiration. So this is just a depiction of where the problem is. So we have a variety of types. We have the mild type that, somebody overeats, they go to bed, and up comes the food. Functional, which is painless and frequent. And usually this is going to resolve as the child matures. Remember that GERD is very common in our preterm infants. So what we do with this functional GERD is we give medications, and we're going to talk about that towards the end of the presentation. And then when we have pathologic GERD, the frequency of it varies, may or may not be associated with eating, may be associated with our failure to thrive kids, because remember, 2 ounces go in and they reflux out an ounce. So they really only got 20 calories. They have recurring aspiration pneumonia or other respiratory complications. The kid is always coughing and choking and may have apnea episodes. This type needs a surgical intervention. So we start with the meds and then we have to go to surgery. So we have to differentiate GERD from just regurgitation of formula. And so babies usually spit up something because we didn't burp them enough. They sucked it down, they got air in their stomach, they're laying down, they can't quite get that air up without sending up a little bit of formula. So 90% of babies who have actual GERD will have some vomiting, but that's different from just a little spitting up. Does the baby have apneic spells when they're feeding? That raises a red flag for GERD. And then as it gets worse and worse and the esophagus becomes irritated, now your kid is getting really fussy. Every time they eat, they're supposed to be sated and feeling good, but now they're fussy. Your older kids are going to actually complain of that substernal burning that you all know as heartburn. If it gets to be real bad, then they start complaining that it hurts when they swallow foods. And it's extremely bad if it hurts when they're swallowing liquids as well. Problems associated with chronic reflux are going to be the failure to thrive, aspiration, pneumonia or pneumonitis, apnea, and then you can cause permanent damage to the lungs. You can have anemia from the repeated bleeding from the esophagus, and then when the kid throws up, now we're going to see blood in it, and then we also may see melena, which is blood in the stool. So what we do with these kids is we get their feeding history. How often are they feeding? How much are they feeding? How much do they throw up when the mother witnesses the vomiting? How's the weight gain been going? Has the kid been following his curve, or is he gradually just falling off? Does this kid have a cough? Does he seem to cough a lot? Are they fussy? Now we do an ambulatory pH study. So in a little baby, of course they're not ambulatory, but we're doing a pH study. So what they do is they send a probe down, nasoesophageal, and the tip of the probe is just above the stomach. And it measures the pH for 24 hours. And so your job is going to be, every time you feed the kid, you have to enter that into the monitor, or the mother does too. We usually will do these on an inpatient basis for our little kids, but the bigger kids can do it outpatient. And then they read the results, and if the pH is 4 or less, that's diagnostic for gastroesophageal reflux because the stomach acid is coming up into the esophagus. Other diagnostic tests are the upper endoscopy. They can do a pneumogram if this kid has repeated apnea, and basically that's about all we're doing. When we're doing the pH test, we need to put some elbow restraints on the child so that they don't pull the probe out. You need to do the recording. We want this kid on a cardiorespiratory monitor just in case there's an apneic event. Make sure you know where your resuscitation equipment is. And then teach the parents how to record. And it's very important that before this child gets discharged, that you teach the parents CPR and you get a return demonstration. The non-surgical management includes feeding the child smaller volumes more frequently, even if it means we have to give them a higher calorie per ounce formula, but a smaller volume. We can give them what we call an elemental formula, so it's not going to be just your straight Similac or Enfamil, but we're going to go to these pre-digested like Progestamil or Nutramigen, because it's easier for the stomach to digest and move forward. We can thicken the formula with a little bit of cereal, and what that does is it helps everything stay in the bottom of the stomach. But we have to give it through a cross-cut nipple because the formula won't go through. It'll get stuck. And last but not least, NJ or GJ feedings, but that's going to be the extreme. We want to feed this child upright, and then we put them on GERD precautions. And you can see this little guy is at a good 45-degree angle. You want to burp them on your lap. Avoid shoulder burping. You want to just gently tap their back until their air comes up. Avoid putting them in an infant seat after they've been eating, because the baby slides down and it actually compresses the abdomen more than if the baby is just put in a position like they are on this bed. Now, of course, this child's in the hospital on a monitor, but typically we would not put this child on their bellies. Medication. We can give antacids, so Maalox or Amphigel, because it'll neutralize the gastric acid. And we give this after meals because the acid is increased with the meal. We can give them Pepcid or Zantac. We tend to give more PPIs than the H2 blockers just because it's only once a day. And then we give the prokinetic agents, as in metoclopramide, which you're used to giving for nausea and vomiting. But what this does, it increases the pressure at the lower esophageal sphincter, and it speeds food going and formula out of the stomach, so because it's a propellant. So we want to give this about 15 to 30 minutes before a feed. Now, we do have to watch for side effects, which are the tardive dyskinesias, which you should be very familiar with after learning psych drugs. We can give Carafate, and what this does is it completely coats the inside of the stomach. But this is given an hour before meals and at HS, so 4 times a day. And then we put them on the monitor and teach CPR. If this child fails medical management, then they actually have a Nissen fundoplication. It's the same thing that you learned with your adults who had gastroesophageal reflux. They might also have a G-tube or a GJ tube, and this is very common for our special needs children. So they may end up with a Nissen, plus they're going to get a G-tube because they are always feeding in their bed or in a wheelchair, and they can't move around after eating. And having a G-tube allows us to decompress the belly, so we can leave it open and the air can be expelled. And for kids who have a lot of reflux, we do the drip and gravity method so that we're not giving them a big volume all at one time. And we can also use it to administer our meds. So this ends the lecture on reflux.